Okay, so now what I want to do is just take you a minute to show what each picture means. Again, for some of you this will be review, but again, it's the best way to do this is just to go ahead and open our program, the Dawson Diagnostic Wizard that we're training you on. And if Sarah was the last patient that we looked at, she'll be right there, and so when we click that open, the data, we had done a complete exam for her, all the examination data would be there. And of course, there are the photos that Kristen has loaded in. And so the first thing I'm going to do on that lower occlusal shot is just flip it upside down. So now everything's there. So let's go ahead and hit on this 2D exam. And I'm just going to go past the functional questions that we would normally be looking at with our articulator. And let's just go ahead and look at our photos and look at what each one of them mean. And again, being mindful of how important it is when we're looking at our pictures that we have the right angle, that we've taken the picture in a way that the patient's in natural head posture, that occlusal plane is parallel to the floor so we're not seeing any cants. Now, what we're going to do first is just look at our different tools, and if we go ahead and unlock the photograph here, we have the ability to go ahead and bring this picture and magnify it in any way and then lock it down. Now the first thing we're going to look at is our next true vertical line, and in our next true vertical line, what we like to see, let's even get this in a little closer so it's a lot like what we see in our example here, that we'd like to see if we drop a plumb bob from basically the base of the nose as we are here, we want to see the upper lip 2 to 5 millimeters ahead of that line, the lower lip on the line or 3 millimeters ahead, or the chin on the line or 4 millimeters back. And so we can see with Sarah here that she really has a pretty optimum facial symmetry from looking at our next true vertical line. Here again, you can imagine though, if this picture had been taken with her head too far back or too far forward, that would be problematical. We wouldn't be able to see what we need to see. So that's why when you're taking the picture, the best thing to think about when you're looking at the profile is that maxillary plane is parallel with the floor, or just ask the patient to have their head postured in the way like they would be looking at themselves in a mirror. So if they're looking at themselves in the mirror, patients don't do this or do this. They will have a natural head posture that will be optimum. The next thing we're going to look at is the nasolabial angle. And in the nasolabial angle, we're going to get a little closer so that we can go ahead and put the tip of our measuring right on the base of the nose, and then we can go ahead and orient these little balls such that we can see this nasolabial angle ideally. So again, what we tend to see in men is a nasolabial angle that is 90 to 95 degrees, where women's nasolabial angle will be a little more obtuse. 95 to 105 degrees is pretty much the range, and we're seeing Sarah's at 100 degrees, which is again pretty much ideal, which is why pretty gal. I mean, everything is in pretty good shape here. The last one is we're going to look at is Ricketts E-plane. We're going to get a little closer, and let's get one more click and essentially unlock it so that I can get these lines such that they're on the tip of the nose and the tip of the chin. And what we want to see here is about twice the distance from the upper lip to that line than the lower lip to the line. What we find with patients that are very class 2, that both lips will almost penetrate that line. If the chin is way back, you're going to start noticing that you'll have very convex facial profiles. Similarly, a class 2 patient, you're going to see the chin far away from the true vertical line and the lip way back. So we start recognizing patterns real quickly when the skeletal components aren't ideal. But that's how we're using these facial pictures. Let's look at the next one, and this is that kind of creepy picture we take with the retracted view, the full face retracted. But one of the things I want you to notice is that we're going ahead and aligning that such that we're basically trying to penetrate the interpupillary line with that horizontal line, and then we can start centering this into the right in the center of the nose, and looking at midline. And with her tooth midline is slightly to the right, so that's something that we want to be able to see and discuss whether we think we need to fix that or not. But it is slightly to the right. But one of the things we notice is that her maxillary occlusal plane is absolutely parallel to the floor. There are no cants, which is something that we want to look at. So that's what we're looking at. This is her pupillary line with her occlusal plane to see what we can see here. And then also notice her lower incisal plane is all pretty well, looks pretty good. Similarly, if we get this oriented just on the dental midline, we're also looking at where the centrals are in relation to the line, where the laterals are in relation to the line, where the canines and bis, and we're starting to see when we compare her to our model over here to the goal, everything looks pretty good. Let's look at the next one, and with the next one we're really looking at the lower incisal plane in relationship to the lower posterior occlusal plane. And the reason that we take these three pictures where the teeth are slightly apart is that we can really see, particularly on the left side and the right side, the lateral shots, where the incisal edges are in relationship to those buccal cuss tips. We also have a tool that we can put basically on the tips of the canines and on the incisal edges, and just to see if everything is level. What we don't want is we don't want to see planes that are concave. That's really an indication that there may be an anterior-posterior bruxing problem, and we have to start deciding whether we're going to add to the lower incisors or take away from the canines. So these pictures really help us see that. And the other thing on this picture, we have a drawing tool that, let's try it from this way, drawing tool that will allow us to just mark where the arch form is. And so if there's crowding or whatnot, teeth that are out of position, we can really visualize that. We get to the next pictures, and notice on this page it's all about looking at the upper incisal edge position. So we have a smile picture we look at the rest picture, we look at the E picture, and we look at the tip down smile and the horizontal position, the horizontal shot or the 90-degree shot. Let's look at each of them, and again with the idea when we look at our model here, we want to see that the incisal edges follow the smile line. In this model we see that this patient has a lot of curve to her lip, and the incisal edges follow the curvature of lip. When we look at Sarah here, similarly she has a curvature where her incisal edges nicely follow the curvature of the lip. The most unattractive smile we see is when the lip goes this way and the teeth go the other way. That's when they just have a black space in the front of their mouth. So here again, that's pretty ideal. But what if it's deficient? We can start to see that there's going to have to be some length change to be able to fit the lip. And this is important because remember, you can't see the lips on an articulator. So being able to make some assessment here becomes important. The rest position is one of the pictures we look at to determine vertical length. And the rule here, if you look at our model, the rule says that at age 30 you should see about 3 millimeters of the maxillary tooth structure at rest and about 0.5 millimeter of the mandibular incisors. So if we look critically at Sarah's smile, she might not be showing as much as we maybe would see in somebody else, but she is showing some tooth structure. Sometimes the reason we don't have to see a lot at rest is because if there's a big smile, the lip may move a lot. So that's why we always compare the rest picture with the E position picture. And when we have that patient say E, it's a dynamic movement of the upper lip. Now, the rule is that when they're saying E, you want that incisal edge at least at the halfway point between the upper and lower lip. So the space created by the lip, we want that halfway point. And so the tool, we can drag these down and we can put these at the edges of the lip. And what we're finding with Sarah is that at the 50% line, that's right where her incisal edges are. So in fact, her centrals are right at the proper length on the shorter side of normal, which we would accept. The last one, it's critical, and a lot of us forget to look at it, is looking at where the teeth are in the horizontal position. In other words, are the incisal edges too far out or too far back? When we look at the model here, notice when we tip the chin down, we see the edges following the inner vermilion border of the lip. And when we look at Sarah here, our patient, it's dead on. And when we look at her profile smile, just like our model, the incisal edges are right on the inner vermilion border. So sometimes you're seeing people maybe that had restorative dentistry done and it doesn't look right. And what you often find when you look at this picture is these edges are out, these incisal edges are out over the lip. And that would tell us that we need to bring them in orthodontically or restoratively. We go to the next one, and we're looking at the teeth behind the canines. And as we look at the teeth behind the canines, we're just making an assessment of how far the smile goes back. And if we were going to do a big color shift on Sarah with veneers or something, we'd want to know how far to go. And that's why the smile from the frontal view and the smile from the side view allows us to see the teeth that are in play. And it's interesting, isn't it? We tend to see more of the teeth on her left side than the right side. Why is that? It's because we've already seen that her midline is a little bit over to that way. So you're seeing more teeth on the other side. All right, so we move on. One of the things, again, we just want to make sure is that we don't have a hypermobile lip. So the pictures that auto-load in the wizard that get put here is we're comparing the rest position to the E position. And again, when we go between, the rest position to the smile position. And again, with Sarah, she really doesn't show a lot of tissue. She probably has the normal amount of lip movement, which is around 8 millimeters, but we don't have a lot of worry to having to really be picky about the gingival asymmetry, unless, of course, the patient wanted us to look at that. Now, as we get into the mouth and start looking at the position and contour of the tissue, notice that we want the centrals to be dead on. We want the laterals to be slightly lower than the centrals, and then the canines back somewhere at the same height of the centrals. And of course, this is our model. So when we go back to Sarah, if we put this on the height of the centrals, what we can see is everything looks pretty good. We might have a slight discrepancy on the right side. This is slightly more tissue on this canine than over here. Our lateral on tooth number 10 looks reasonable, but notice we're showing a little more tissue on that right lateral. Now, Sarah's in the middle of Invisalign right now, getting towards the end, so when we get done with treatment, if that's still an issue and she wants to change it, that might be something that we can take care of with a laser or something along those lines. Okay, so now we're getting really detailed now and getting into the position of being able to specifically measure teeth. Now, one of the measurements we took on Sarah clinically was the width of her central incisor, and that's something we need to put in. And her central incisor was 8.5 millimeters wide. And so what we're going to do is we're going to essentially get a little closer. I'm going to center my picture so that the center red line is dead in the middle of the embrasure between the centrals. And I'm going to take this outer blue line and put it on the distal aspect of tooth number 9 here. Now, what this is doing from the red line to the blue line is it's telling the computer that from here to here is 8.5 millimeters. And it now will measure the pixels between those two, the red line and the blue line, so that we can actually measure in the software now. Now, proportionally, we can take our red lines in and put them on the outer aspects of the canines, and it shows us that what the proportion should be. Now, she's within 0.1 millimeters of the ideal width, and that's pretty darn good. as a general rule, you may remember that if you assign a value of 1 to the mesial distal width of the lateral, as we're showing in our model here, the central should be 1.6 times the width of the lateral, and the mesial third of that canine should be 0.6. So with Sarah, the proportions of her teeth look really, really good. Now the other thing we can do with this software is essentially measure the width-to-length ratio of the teeth. And again, if we're looking at the size and shape of her central, notice as I bring this down, it changes again in millimeters the size and shape. Sarah's actual width-to-length ratio right now, she's 11.3 millimeters with a width of 8.6, and she's essentially a 76 width-to-length ratio, which is we want it between 75 and 85. And I find narrower is a little more attractive. But here again, if we were going to make changes here and we decided that we wanted to add a millimeter of length, we could drop down a millimeter and see what that would essentially be. And then if we drop the red line down to follow it, we can see what effect that would have on the width-to-length ratio. We'll have some more advanced discussion about this later, but here again, I want you to really get a grasp of how important a properly framed picture is for us to make these decisions. We go to the next one, and we use the close-up view, the standard retracted view with the teeth together to look at the papillas. And again, in her case, we're looking for any black triangle, and there are none. So that looks really good. One of the last ones too is the axial inclinations of teeth, and what we have here is our model showing us that all of the teeth should be, the crowns of the teeth should be aiming towards our belly button a little bit. We don't want them flared out. And if we look at Sarah, it's one of the reasons we're doing the Invisalign, the roots of the teeth aren't in the best direction. And so this little tool, this drawing tool, helps us visualize that to talk to patients if we're going to be making a change to essentially the position of the teeth. So that's an issue. And then the last pictures we take, we've got 3 views. We've got the smile, we've got the retracted view, and then we've got these close-up shots. And notice, particularly with the close-up shot with the black background, how well we can see these embrasure spaces. And so we're being asked, is the depth of the incisal embrasure appropriate for the patient? Well, again, Sarah's a younger woman, and to have a lot of curvature to the incisal edges, I think is very feminine and attractive, and she definitely has that. Notice how the embrasure gets deeper the further we go back in her mouth. That's what we want to see. That's the rule. If you've got a patient that's really worn out their teeth, this is the picture that really allows you to see how flat the edges are and how we can make some of those changes. But being able to visualize this from the smile, from the retracted view to the one-to-one is key. So just in a nutshell, what I want to just again reiterate is that there is definitely a reason we take these pictures, but if we don't take them properly, they are not diagnostic. If we don't take them properly, often with editing software, we can't fix them. So the more that we just take the extra few minutes to get the patient positioned right, the doctor positioned right, the camera set right, then we can fly through these pictures and get really good ones. A good assistant that works with this for a couple of months will be able to take this series in about 10 minutes. And for the doctors in the room, I just want to implore you that one of the best things we can do to get good pictures in our practice every time, and I've said it a million times, is to fire the dentist as the photographer. Spend the time to train the team, look at these videos, and practice. And then what the doctor's job is to hold the standard so that they can check the pictures. If they're not right, that they can coach the assistant and give them some resources like this so that they have good skill. Beyond that, load the pictures at the time of the exam into the software so that the doctor has the time to then look at it and make the appropriate decisions. Treatment planning is the name of the game in the Dawson Academy protocol. And if you just spend the time getting good data and using this systematic approach to analyze it, you're going to have really consistent treatment plans. So with that, good luck.